Of intra-abdominal pressure on the clinical levels of transpulmonary pressure. So as you know, patients with higher intra-abdominal pressure are characterized by a cranial shift of the diaphragm, and this is associated with a reduction in the lung volume and changes in the mechanical characteristics of the respiratory system, mainly the chest wall. And we'll talk a little bit about the role of intra-abdominal hypertension on the lung and chest wall distension, recruitment, and also its role to develop ventilator-induced lung injury and some clinical suggestions. This is a nice experimental study in animal showing that increasing the intra-abdominal pressure here, we have an increase in the plateau pressure of the respiratory system, which is the most common variable that we measure and we look at on the ventilator. On the other side, the increase in intra-abdominal pressure is associated with a reduction in chest wall compliance. So the message from this slide is that when in any clinical situation in which we have an increase in intra-abdominal pressure, plateau pressure does not reflect the real transpulmonary pressure. As you can see here, exactly the same animals, you see the increase in the sufflation pressure in the abdomen. So this is the intra-abdominal pressure. And you see that the transpulmonary pressure does not change, while the plateau pressure of the respiratory system changes. So the conclusion here is that whenever we have an increase in intra-abdominal pressure, mainly above 15 centimeters of water or 16, the plateau pressure of the respiratory system does not reflect anymore accurately the real transpulmonary pressure. And this is a study from Franco Valenza showing that this is the esophageal pressure at end expiration, and this is the delta transpulmonary pressure, esophageal pressure. And you see that when you have an increase in intra-abdominal pressure, at least in animals, there is no major changes in the esophageal pressure at end expiration. There is, of course, a change in the delta esophageal pressure because the chest wall compliance is reduced. And this has a major effect on the, for example here, central venous pressure. So we have two messages here. When we increase intra-abdominal pressure, there are no changes in the esophageal pressure at end expiration, and this is linked to what was Gattinoni showed before. And this can a major impact on the absolute value of intravascular pressure that we will discuss a bit later, which is the relation in patients between the chest wall elastance or compliance. Sorry, because of some studies looking at the chest wall elastance, some of the chest wall compliance, and intra-abdominal pressure. Below 12 millimeters of mercury, not centimeter water, so it's 16 centimeter water of intra-abdominal pressure, more or less most of the patients, they have normal chest wall, with some few exceptions. When the intra-abdominal pressure is higher than 20, 22, what we call now abdominal compartment syndrome, we are very likely in most of the patients to have a deterioration in chest wall elastance. Then we have a gray zone, which is the most common one in the clinical practice, and you can see that between 12 and 20, 22, some patients they have a reduction in chest wall elastance, some patients they have normal chest wall elastance. So if we want to get information, we theoretically and practically, we should really measure the chest wall compliance by using the esophageal pressure. And these are data in patients, and they confirm the data in animals showing that esophageal pressure at end expiration with increasing intra-abdominal pressure. Unfortunately, I mean, in this study, we have not many patients more than 20 because these patients are rare. There was no relationship between intra-abdominal pressure and esophageal pressure at end expiration, as I showed you before in animals. What about intra-abdominal pressure and ventilator-induced lung injury? You see here several studies. These are studies showing that with time and two groups of animals, normal animals with very high intra-abdominal pressure and lower intra-abdominal pressure, with time there is an increase in extravascular lung water, which means that we are developing ventilator-induced lung injury. And this is histological images at 24 hours in control, in non-dependent and dependent, at 24 hours with 15 millimeters of mercury or 30 millimeters of mercury of intra-abdominal pressure. You see that a normal lung, after a few hours, in condition with higher intra-abdominal pressure, they develop a sort of lung injury. So intra-abdominal pressure per se, especially when it's higher than 20 millimeters of mercury, is associated with lung injury per se. And this is a study we performed some years ago with Michael Quintel, showing here these are animals after oleic acid at two different levels of intra-abdominal pressure and different pressures in the airways. And you see that when we apply the same airway pressures, as I showed you before, in the slide before, we have a complete different effect on the lung structure. Because in this condition, we apply the same airway pressure, but the real transpulmonary pressure here is much lower than in this setting. So again, in order to evaluate the real transpulmonary pressure in this condition, theoretically, we need the real transpulmonary pressure. These are other very recent data from John Marini group, showing that here there are different intra-abdominal pressure in animals. So this is the FRC. Now we'll talk about the effect of PEEP in a condition of higher intra-abdominal pressure. What they found was that, at least from this study, if you want to keep the FRC, which is one of the parameters we can look at, we have to apply a PEEP at least equal to the intra-abdominal pressure, at least within 15 or 16 centimeters of water. When intra-abdominal pressure is higher than the external PEEP applied, you can observe a reduction in the lung volume. And again, coming back to the role of absolute transpulmonary pressure, this is again a study from John Marini group. This is the transpulmonary pressure at expiration and inspiration at lower PEEP at different intra-abdominal pressure. And you see that in most of cases at the pressure, the transpulmonary pressure at end expiration, if we believe in the absolute transpulmonary pressure, is negative, and just only increasing the pressure here, especially when the intra-abdominal pressure is increased, we need a little bit higher PEEP to counteract this reduction in transpulmonary pressure. This is the last experimental study that was published, and you see here the end expiratory lung volume and different intra-abdominal pressure with different proposals. Here is the PEEP5, and you see that increasing the intra-abdominal pressure, the lung volume decreases. Here, very high PEEP at 15. Here, when the PEEP was set at half intra-abdominal pressure plus 5 centimeters of water, and this is when PEEP was applied according to EAP. And you see that the PEEP, according to this study, the best PEEP to keep the lung volume was the PEEP set like half of the intra-abdominal pressure plus 5 centimeters of water in terms of lung volume. And this, again, this square, is the level of PEEP, at least from these animal models, to maintain also constant hemodynamics. If you apply too high PEEP, this can be associated, as you can see here, when you apply PEEP equal to intra-abdominal pressure, we have a major reduction in cardiac output, because of course PEEP, as we learned before, is always associated with changing hemodynamics. So from these studies, it appears that one solution is to apply an external PEEP in presence of higher intra-abdominal pressure equal to the half of intra-abdominal pressure plus 2-3 centimeters of water. Now I show you some data from animals that we did with Patricia Rocco in Rio. This is a study in which we look at the effects of different tidal volumes, so different transpulmonary pressure, in two conditions with a model of pulmonary RDS and a model of extrapulmonary RDS. And this is what we found in a model of pulmonary RDS. This is the area of collapse with two different tidal volumes, without and with experimental model for intra-abdominal pressure. And what we found was that in a model of pulmonary RDS with more consolidation, intra-abdominal pressure did not affect too much the amount of atelectatic tissue. And this was also not affected by tidal volume that, on the other side, you can interpret as a transpulmonary pressure. On the other side, when we look at the expiratory secondary extrapulmonary lung injury, you see that we observed a major increase in the atelectasis, and with increased tidal volume, we observed a reduction in this atelectasis at the same level of relatively lower level of PEEP. The hypothesis is that if you use excessively low tidal volume and excessively low transpulmonary pressure in a condition of higher intra-abdominal pressure, we observe a higher amount of consolidation, amount of atelectasis, and this can produce further lung injury. And this is actually what we observe when we increase the tidal volume. So we use the excessive transpulmonary pressure in pulmonary RDS in presence for intra-abdominal hypertension. We found an increase in the lung damage, as observed here with an increase in interleukin 6 in the lung. On the other side, when we observed a reduction, an increase in the atelectasis by using lower tidal volume and lower transpulmonary pressure in presence of an secondary lung injury, you can see here, this is just one example, a reduction here in the interleukin 6 and many other mediators in the lung. So if we use too low inspiratory transpulmonary pressure in a condition of higher intra-abdominal pressure, this can promote further atelectasis and further damage. So we did a second study we just recently published, and we look at the effects only of PEEP with a constant tidal volume. Again, we found here, this is the effect of PEEP on collapse and hyperinflation. What we found that in the extrapulmonary lung injury model, we found a reduction in collapse when we increased PEEP. This was less evident in pulmonary RDS. However, in both conditions, we found a high increase in hyperinflation when we increased PEEP. On the other side, when we look at the type 2 and type 1 epithelial and cells damage, we found that higher PEEP, independently from the type of the disease, increased markedly the damage. And the other side, when we look at the inflammatory mediators, as you can see here at lower and higher PEEP, we found an increase in the inflammatory mediator when we increase PEEP, especially in the model of intra-abdominal hypertension with extrapulmonary lung injury. So these experimental data suggest that we have to be anyway cautious to increase too much PEEP in condition of lung injury. And in fact, we have to remember that when we increase the intra-abdominal pressure and we apply higher PEEP, this compresses the lymphatic flow and increases also the pulmonary pressure, so reduces the venous return with a further increase in the edema of the abdomen. So the message here is that we have to take care to increase too much PEEP in condition of lung injury, especially when intra-abdominal pressure is too high and especially higher than 20 millimeters of mercury. In fact, as shown in this slide, you see that we can really recruit the lung only if the intra-abdominal pressure is not so high. But if you have a very major increase in intra-abdominal pressure and we increase very much PEEP, because we believe that we have to counteract completely the intra-abdominal pressure, we have little space to open up these areas because we have a very rigid chest wall. And we reduce the dimension of the heart, so we reduce the venous return and we have impaired hemodynamics. On the other side, in these patients, one possible solution is to reduce the intra-abdominal pressure eventually with open abdomen. Of course, I'm not advocating to open abdomen all these patients, but just to think about when intra-abdominal pressure is higher than 25 millimeters of mercury. Then we did another study in patients looking in intra-abdominal hypertension, which was the best method, again, to set PEEP in patients. And what we found, as you see here, this is the elastance at different level of PEEP in patients with and without intra-abdominal hypertension, which was not so high, so not higher than 20 millimeters of mercury in this case. The elastance of the respiratory system was a good method. So to conclude, we have now evidence that when we have patients with increased intra-abdominal pressure, we have to use protective ventilation with low tidal volume. However, be aware that if the reduction in tidal volume is associated to a major reduction in inspiratory transpulmonary pressure, this can promote further atelectasis and eventually lung damage, even if these data are mainly experimental. One possibility to set optimal PEEP in these patients is to look at the best elastance of the best compliance, or, as I show you from some animal data, applying a PEEP equal to the half of the intra-abdominal pressure plus 2-3 centimeters of water. On the other side, remind that in presence of intra-abdominal pressure, we have changes in the dynamic changes of the pleural pressure, so this can affect the interpretation of intravascular pressures. So the central venous pressure or the wedge pressure has to be corrected for their interpretation on the measurement of intra-abdominal pressure. So I advocate the measurement of intra-abdominal pressure in these patients in order to have a better interpretation of intravascular pressures. Overall, we believe that echography is very, very important in these patients, because in these patients we can get information on the lung structure, and I show you that intra-abdominal pressure can markedly affect the lung edema and eventually the lung injury. We can get information on the volemia by looking, for example, at the vena cava and other parameters, and I show you that the interpretation of absolute pressures in the vascular system in presence of increasing intra-abdominal pressure and changes in the pleural pressure can be questionable, so it's better to look at that. And of course the heart, which is the third element in the thorax that we have to look at, because I show you that changes in the airway pressure can markedly affect hemodynamics in these patients. So, to conclude, intra-abdominal hypertension or even more abdominal compartment syndrome markedly affect physiology of different organs and mainly the respiratory system in terms of mechanics. I show you the effects on the airway pressure and chest wall, the edema and ventilator-induced lung injury. Esophageal transpulmonary pressure might help to optimize the ventilatory setting in these patients. I show you some data that can suggest that even the titration of tidal volume can be important in this condition. Low tidal volume has to be recommended with some consideration before, and PEEP can be set with different methods or according to the best compliance of the respiratory system or according to the intra-abdominal pressure with this formula. In abdominal compartment syndrome, when the intra-abdominal pressure is very, very high, higher than 25 milliliters of mercury, we have to call a surgeon first and to detect the main cause of the disease. But we have to consider very carefully to continuously increase PEEP, because this can negatively affect hemodynamic and the respiratory system, and eventually to increase a little bit more tidal volume and to keep PEEP a little bit lower, even if we have no clinical data suggesting that this can be the optimal strategy. Finally, volumetric hemodynamic monitoring, and I think that the echography will have to play a major role in the next future in our critically patient. It suggests, especially when the esophageal pressure and transpulmonary pressure is affected by increased intra-abdominal pressure. Thank you very much.